In the previous session, we have elaborated on the effect of pregnancy on carbohydrate metabolism and the adverse effect the diabetes has on the mother and the fetus. To avoid this complication, we have to control the diabetes, which means we have to diagnose diabetes as early as possible. This makes screening of diabetes in pregnant women mandatory. The prevalence of diabetes is increasing compared to the previous decade in our country. This is due to the increase in obesity in the population, the change in the lifestyle of the population, and the increasing age at which the woman becomes pregnant. We know there is ill effect of diabetes on the fetus and the newborn, on as well as on the mother, and effective control reduces the complication. Even by effectively controlling the diabetes, we can prevent the long-term complications of diabetes on the mother and the fetus. It can like type 2 development of type 2 diabetes, metabolic syndrome, cardiovascular complications. All these complications can be prevented or at least delayed if we have a proper diagnosis of diabetes during pregnancy. Screening for diabetes in pregnancy may be of two types. One is we look for risk factors for developing GDM and screen those women who are high risk for GDM. Or you can adopt for a universal screening where all the women, irrespective of the risk, are screened for diabetes. The risk factors for developing gestational diabetes mellitus are age more than 30 years, if there is a family history of diabetes mellitus, or if there is a previous history of GDM, macrosomic baby, unexplained stillbirth, neonatal death in the previous pregnancy, if she is obese, or if she belongs to an ethnic group where there is a high incidence of diabetes mellitus, if there is a history of suggestive of polycystic ovarian syndrome, if she is hypertensive, in this pregnancy, if there is polyhydramnios, recurrent vaginal candidiasis, or persistent glycosuria. So which type of screening we adopt for or opt for? We can either it is universal or higher risk. If we take only high risk women and screen, we may miss 50% of the GDM patients, which may not be suitable in a country like India, where we belong to an ethnic country where the incidence of diabetes is very high. And remember, India is considered as the diabetic capital of the world. So the high risk screening may be suitable for countries where there is only low risk, low incidence of diabetes mellitus. In India or in our state, we opt for a universal screening, where irrespective of the risk factors, all the pregnant women are screened for diabetes. When we decided to screen the woman for diabetes, then the next question is when to screen and how to screen. It is recommended that every woman should be screened at the first visit or in the first trimester. This is because the diabetic being an asymptomatic disease in the early stages, we may miss an over diabetes if we postpone the screening up to the second trimester. And almost all the associations like WHO, American Diabetic Association, International Association for Diabetic in Pregnancy Study Group recommend screening all women in the first trimester or in the first visit itself. And this includes all women excluding women who are already diabetic. And how to screen? There are different methods for screening. One, we can adopt a fasting blood sugar, a glycosylated hemoglobin, or a random blood sugar, or a classical OG-TT. And it is recommended that we opt for a one-step screening method, which is a 75 gram 2-hour oral glucose tolerance test. In a low resource setting like India, it is more feasible to opt for a DIPSI criteria, even though it is less sensitive but more specific, and it is recommended by the Ministry of Health and Family Welfare, Government of India. If one is planning for a 2-hour 75-gram oral glucose tolerance test, the woman should be fasting overnight, and she should have a fasting blood sugar value, followed by a 75-gram glucose is given in 150 to 200 ml water or lime juice, and take 1 hour and a 2-hour value. She should not take any food in between. And cutoff values recommended are fasting blood sugar should be less than 92, 1 hour value less than 180, and 2-hour value less than 152. If any value is more than that, more than or equal to the cutoff, it is taken as diabetes. And if the fasting value, if it is between 92 and 125 milligram percentage, it is taken as JDM. And if the value is more than or equal to 126 milligram percentage, she is taken as over diabetes. And coming to 2-hour value, if the value lies between 152 to 199 milligram percent, she is taken as having JDM. Or if more than 200, equal to 200, considered to be over diabetes. And to diagnose diabetes, any one values, if abnormal, she is taken as having diabetes. Those who are negative to screening are again screened at 24 to 38 weeks, because majority of the women didn't develop in the second trimester. The advantage of these criteria is that the woman may not come to the clinic with the fasting. We know majority of the women when we ask for a second visit, they may not turn up. So to avoid that, at the first visit itself, irrespective of her first stage or food intake, one can give 75-gram glucose in 150 to 200 ml water or in lime juice. And this is based on the principle that if the patient has sufficient pancreatic reserve, a 75-gram glucose load will not affect the blood glucose level adversely. And we get only those patients who doesn't have a pancreatic reserve will show abnormal result. And after giving 75-gram glucose, if the woman vomits within half an hour, we have to repeat the test the next day. Or if she vomits only after half an hour, you can go with the test. And a 2-hour plasma glucose is estimated after the 75-gram glucose, and the result will be available while she is waiting in the first checkup in the antenatal clinic. And cutoff for as per DIPSI criteria are, if the value is 2-hour values less than or more than or equal to 140 milligram percent, she is diagnosed to be JDM. If the value is less than 140 but greater than 120, then she is said to have impaired glucose tolerance. And if the value is more than or equal to 200, she is considered to be over diabetic. And it is testing is done at the first visit, and if negative, has to be repeated at 24 to 28 weeks. Previously, we have been using a 50-gram glucose challenge test at 24 to 28 weeks for screening, and if the and take a 1-hour plasma glucose value. If the 1-hour plasma glucose value is greater than or equal to 140 milligram, then we do a 100-gram oral glucose tolerance test. But this will 50-gram glucose tolerance test may take up only 50% of the diabetic, and since the test is done only at 24 to 28 weeks, we may miss the pre-gestational diabetes or the over diabetes. So it is now not recommended to have a two-step screening.